I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support. And we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Well, today we're honored to have Dr. Dorianne Miller speak to us on approaches to community engagement research, listening, learning, action. Dr. Miller is the inaugural director of the Center for Community Health and Vitality and the director of Health Equity Integration for the Institute of Translational Medicine at the University of Chicago. Prior to joining the University of Chicago in 2009, she served as the National Program Director of New Health Partnerships, a demonstration project funded by the Robert Wood Johnson Foundation and the California Healthcare Foundation on collaborative self-management support. She worked for 5 years as a program vice president at the Robert Wood Johnson Foundation, where she was responsible for strategic planning and program designs, and programs that flourished under her direction included demonstration projects designed to improve quality of care for people with chronic health conditions such as asthma, diabetes, and depression. She's previously served as a member of the 2002 Institute of Medicine Committee that produced the report on guidance for the national healthcare disparities. In addition, Dr. Miller has been a recipient of several awards for her community-based efforts. A general internist, Dr. Miller cares for patients in her primary care group at the University of Chicago Medicine. Dr. Miller, welcome, and we are honored to have you and look forward to your presentation.
Thank you so much for that kind introduction. I'm very happy to be with you today and sharing information with you about approaches to community engagement and research. I am going to share my screen here, and I will ask you, if you would please, to hold your questions until the end. If you'd like, you can drop them into the chat, and we should have about 15 minutes or so towards the end for any questions that come up. The reason why I put in the subtitle for this talk, Listening, Learning, and Action, is because oftentimes when we are doing work in partnership with community, actually the first steps are being able to observe and to listen and to learn with community partners. And so before we're even able to think about ways in which we can formulate partnerships in community engagement and community engaged research, being able to listen first is absolutely critical. And so in terms of our objectives for today, I will go through the definition of community engaged research and also to provide some understanding about the range of community engaged research, as well as reviewing some of the benefits and challenges of community engaged research. And then I'll end with 2 case examples of how community engaged research is responsive to community needs, one of which will be a present day project that I've been involved with over the past few years, but also for those of you who are earlier in your career development, I'd like to share with you my first foray into this work in community engagement and how the paradigm of listening and learning before taking action was applied in that particular situation. Let's start out with a bit of a definition. This comes from a community engaged scholarship in the health professions convening that was done by the W.K. Kellogg Foundation at this point 20 years ago with the definition. And I think that this is very applicable to the work that they're doing through our various grants and in fact, in my scholarship over the years. And that is community engaged scholarship is a scholarship that involves a faculty member in a mutually beneficial partnership with the community. And I highlighted the words mutually beneficial here because I think that as we think about partnerships and the range of community engagement in terms of research. Sometimes the partnerships that are developed do not necessarily have mutual benefit or even equitable benefit with the communities that are involved. And so, again, I think that this particular issue of mutual beneficence and equity is very central to the partnerships that are developed. The slide that you see in front of you is derived from the sociology literature from Brager and Speck, which looks at a ladder of community participation and also the participants' actions and how one can achieve it. And so as you look at this scale, starting at the bottom of the page for low and going up to high control, you can see examples of where the community is engaged in this particular work. And for our purposes, the organization should be considered to be the university or academic partner that's involved. And it can range from as low as the research that's taking place in which the community is told absolutely nothing about the project. Sometimes you can see this referred to in the literature as helicopter research, in which investigators go into a community, conduct a project, and then leave, and oftentimes leave without leaving anything for the community behind. But as you can see, going up the scale from the bottom to the top, there are different levels of participation in which the community is either just receives information passively. I think that the line of compliance is expected is actually very telling in terms of how the studies are being conducted, versus consultation, versus the actual advice that a community member gives in terms of presenting a plan, inviting questions from the organization. But actually, to some extent, it's still much more of, we will take your advice and we may or may not change our plans depending upon what our protocols tell us. And then as you go higher up on the scale, it's a question of having a set plan versus a tentative plan from the academic partner with expectation of having the plan to change, and also planning jointly. The issue of delegated authority includes the organization and the community, namely the academic partner, coming together and identifying a problem together, and then asking our community partners to make a series of decisions that are incorporated and embodied into a plan which both sides accept. So again, going back to the definition I described before, having a mutually beneficial and a mutually agreed upon partnership. And as I go through some of the principles around this in just a moment, you'll see where some of those equity issues come up. And then finally, the question of the community having control. I like to talk about this as having the academic partners being the junior partner in the relationship, and that the organization or the academic partner asks the community to not only identify the problem, but also making all the key decisions on goals and how the work is going to be implemented and accomplished. And then this is the junior partner piece of this, that is the academic partner is willing to help the community at each step to accomplish the goals, but is not taking the lead in terms of doing this work. Another way of thinking about this, and this is a publication that comes out of the NIH Principles of Community Engagement, that demonstrates increasing levels of community involvement, impact, and trust, but also communications flow that I think in some ways mirrors the chart that I just showed on the previous slide. Outreach with some community involvement, and then descriptions of how communication flows between one and the other, versus consultation with more community involvement in terms of getting feedback or information from the community and developing connections. Involvement of the community, which is participatory involvement with communications flowing, not just to the community, but community working with the academic partner and having much more of a participatory model, along with some visibility of the partnerships established there. And then the collaborative model, which is, again, very robust bidirectional communication with the formation of partnerships on various aspects of the project, with each part of the partnership working on development of solutions. And from that comes partnership and trust building. And then finally, the last model, which I think is at the very highest level of the slide that I just showed you previously, the issue of shared leadership, which is final decision-making made at the community level. The entities have a strong established partnership structure, which is codified in written documents along with expectations. And then by doing so, the health outcomes are affecting the broader community. The message around this particular model of leadership, I think, was really driven home to me several years ago by Loretta Jones, who was the founder of the Center for Healthy African American Health in Los Angeles, who said, you and your academic partners may have your MDs, DOs, PhDs, terminal degrees from highfalutin institutions, but the people in my community have PhDs from the streets. And if you're interested in really being able to make a difference in the work that's taking place here through the Center for Healthy African American Families, we really need to have strong bi-directional models and trust and engagement in this way. However, a lot of us who are in academic health centers and even starting off our careers are oftentimes seasoned investigators who see issues, don't necessarily think about ways in which they can partner with community. And so I brought this slide in for you saying, I snuck out of that change seminar too. I'm too unique for that stuff. And so the question of how do we think about this from the faculty and academic perspective is that we have so many things that we can learn and implement from our community partners. But in order to do so, we've got to, first of all, listen. Challenges of community engaged research. And there are challenges on both sides. From the community's perspective, there may be distrust, a feeling of insufficient respect from the university partners, the issue of equity and specifically unequal power and funds within the partnership, and then the identification of what constitutes genuine community. And as I talk through some of the principles in just a moment, I'll highlight this particular issue in a little bit more detail. And then community members are concerned that you people in the universities are so prodding in the way that you're addressing things. And we've got these issues that are in our communities that we really want to have solutions to in a much quicker mode. On the university side, for faculty investigators, they wonder whether or not they're going to be able to sustain careers in the area of community engaged research. And so they are concerned about their ability to not only do good, but also to do well through the promotion and tenure process. They worry about whether or not involvement of community will impact scientific rigor because they're working around issues of community acceptability and feasibility, and so that balance. The needs and problems-based approach is sometimes a concern around these particular questions and taking on the community perspective. And then for some, the question of the quote unquote academic partners being the expert in these things, as opposed to being able to not only listen to the perspectives of our community scholars and citizen scientists, but being able to take that in and to leverage that into mutually beneficial research protocols and relationships. And then finally, the issue of sometimes these things developing rather slowly. However, there are also benefits on both sides. And community partners oftentimes can be very explicit in terms of what's needed for their communities. These are some of the top level issues around what communities need, and oftentimes they're much more specific when you start to have community conversations and to drill down. But communities want to build infrastructure. They're interested in knowing that the programs that are developed are sustainable within their communities, including development of employment opportunities for their particular community members, as well as being able to really show community expertise in a particular area. In addition, the ability to build social capital, because even though you may come in as an investigator on one project, community organizations who are interested in partnering with other academics or departments of public health would like to say that they've built social capital by engaging with you. On the university side, I mentioned both doing good as well as doing well comes up as a benefit. And so it's one of the reasons why, at least in the work that I've done over the past 3+ decades, being able to contribute and to give back to the community has been very important. Being able to share academic expertise and also to engage in scholarship and discovery with community members, and also building social capital with those community members, I think are also the benefits in terms of doing community engaged research. Some of you may be familiar with the organization that's headed up by Al Richmond out of UNC called Community Campus Partnerships for Health. They have been on the scene for over 2 decades now as a support not just for academic partners, but for community members who are interested in working together to improve health and well-being, and in particular, health and well-being in a research space. And so these are some of the principles that have been developed in order to be a bit more granular about how communities and academic partners should work with one another in terms of having a specific purpose for the work, developing a shared mission, vision, goals, and accountability statement, developing mutual trust and respect, as well as genuineness and commitment, and then being able to identify the strengths and assets and needs and capacity on both sides. Equitable power sharing is also critically important in terms of the development of clear partnerships along with clear and open communication. On the other column on the screen, having mechanisms for both decision making as well as conflict resolution, because as we know, even in the best of partnerships, sometimes issues come up that require a little bit of back and forth in order to come to some resolution. Quality improvement feedback in terms of how things are working. It's not just about the outcome of the project, but also the process that's taking place. And then again, the sharing of benefits of accomplishments that take place within the project, as well as a process for closure as things come to an end. The impact of a project on design, the environment of design, evaluation, and sustainability is a piece of this. And again, the question of how do we figure out a way in which we can value the multiple types of knowledge and life expertise that are brought to the project. And this is particularly important for our community members. Some of you may be familiar with the Association of American Medical Colleges Center for Health Justice. I believe the center opened up about 3 years ago, maybe 4. And I think that in particular for the projects that we're doing through this P50 and its focus on health equity, that this is also another organization that has been, I think, very clear about how this is being accomplished through collaboration and partnerships. And so just a little bit of information about what they're doing through this center, including partnerships with public health, community-based organizations, academics, and government entities. And they're sparking not only conversations, but actually multi-sectoral research and collaboration and action in order to make a case that policies and practices ensure that all communities have an equal opportunity to thrive. And so they actually have tools and resources and policies that can support the collaboration of organizations in sustaining multi-sector partnerships. And so this is another resource that you can look to in addition to community campus partnerships for health and the development of your work. Another set of principles around trustworthiness. These were developed by the community partners through the AAMC Center for Health Justice. And as you can tell from the language that's here, even though many of the concepts really parallel the ones that are presented through the community campus partnerships for health, I think that this actually helps to make it a little bit more granular. And that's the reason why I've included this slide. And it has to do with trust. Communities are not blank slates. They are quite educated about their past experiences in working with with academic partnerships, and sometimes that's the reason why they don't trust you, and trust us, I should say. We are not the only experts in the room, again, acknowledging the community wisdom and expertise, and also being able to make action as opposed to just making pledges to the work. If you're thinking about having your work in the terms of community engagement to be done by an Office of Community Engagement, community members say, no, you've got to dig in there and do the work yourself. So having a representative from an Office of Community Engagement as an interface, insufficient. And then also it doesn't start or end with a community advisory board. You really need to get in there and get to know the community. Diversity is more than skin deep, and then there's more than one gay bar, Black church, and one bodega in your community. I think really speaks to the intersectionality of communities and how people see themselves as a part of a community. And so this goes to the issue of partnership versus representation, in that you having representation from people who are working with you that represent more than one sector because they identify themselves as having this intersectionality. Showing your work, I think, goes back to this issue about things being performative rather than substantive. And then also, this is more of along the lines of measure twice and then cut once. If you're going to do this, take your time and do it right. If you need to take a little bit more time to really establish relationships with community-based organizations and to figure out what the issues are, do that in preparation for the study that you're doing. And then finally, the project may be over, but the work is not, in that oftentimes the development of long-term partnerships can allow you to do work in a serial fashion with organizations. And I'll speak to that a little bit more when I talk about the second example in just a little while. I'm going to shift gears a little bit right now to tell you about my first foray into this work when I was actually a general medicine clinical epidemiology fellow at the University of California, San Francisco through San Francisco General Hospital and the founding of a program that I had there. And this came out of my clinical experience in working at one of the community health centers in the Bayview Hunters Point neighborhood in San Francisco. One summer afternoon, Gwendolyn walked into my practice. She was a African-American woman in her early 60s with her 3-year-old granddaughter in tow. She came in for a primary care visit, my first visit with her. And I asked a question to start establishing a relationship with her. And the first words were out of my mouth were, "Hello, welcome. It's very nice to meet you. I see that is your granddaughter visiting you for the summer?" And she said to me, "My granddaughter is not visiting me. I am raising my granddaughter." At that point, I started to ask the question why, and to start to ask questions about what would cause her to be raising her granddaughter. And started looking through the chart and found out that she had multiple missed visits for primary care visits over time, and started asking the question why. During this time, there was actually an epidemic of grandparents who were raising their grandchildren in this particular community, and that 1 out of 3 children who lived in the Bayview Hunters Point community, and I'll point it out here on the screen here, so where you can see southeast here and the 101 freeway, the Bayshore coming in here, it's the neighborhood that's right over in this area surrounding 3rd Street. Hunters Point Shipyard goes out here out to the east side of the bay. And the factors that were involved there were multiple: incarceration, mental illness, homelessness, and even death of the children's biological parents. And in particular, in the late 1980s and early 1990s, the crack cocaine epidemic in the Bay Area was actually quite severe. Just as an aside, the cost of the crack cocaine epidemic was equal to the city and county budget deficit in 1988. So the city and county had a very significant budget deficit. And when they analyzed where the money was going to, whether it be through the medical system, social services, the justice system within the city and county of San Francisco, that is the reason why there was a budget deficit at that time. The response to this was, what should we be doing in order to help to support these families? The program Grandparents Who Care was started as a result of these conversations that I started having, not only with the grandparents that I was seeing in my medical practice when I was a clinical epidemiology fellow, but also with nurses at the general medicine clinic at San Francisco General Hospital. And so we started a support and advocacy group for grandparents who are raising their grandchildren. And we started with voluntary group facilitators, myself, a nurse that I worked with, along with a health educator. We later received funding through the city and county of San Francisco to train grandparents as peer facilitators for this work. And we also developed an advisory board of grandparents, lawyers, social workers, nurses, and doctors who helped to guide us through not only the information and support that we developed through the group, but also to spread the group as well. And in the next slide, I'll talk a little bit about the impact of this. And I put this arrow in to say 1989 to the present, because this group is actually still going on within the city and county of San Francisco. We started getting a fair amount of media attention around this particular issue and were invited to present the work that we were doing through the support group at national conferences. And we also asked grandparents to provide testimony, not only to county, but also state legislators around the challenges of raising children whose biological parents were not in the picture because of the crack cocaine epidemic, I should say. We partnered with UC Berkeley researchers, specifically gerontologists, to study depression in relative caregivers, which resulted in not just 2 publications in the peer-reviewed literature, but also a book that was dedicated to the issues of grandparents who were raising their grandchildren in this space. In 1996, we merged with the Edgewood Center for Children and Families in San Francisco, which was an old organization that was actually founded during the 1849 gold rush, in which people were coming to the state of California, going to find their fortunes in the Sierras and pan for gold. And they would literally leave their children on the streets of San Francisco as orphans. And so the organization, very well known and respected for their work in caring for children since the 1800s. As a result of this work and some of the partnership that we had with the UC Berkeley researchers, there was a development of a California kinship network, which exists in 20 counties with support of grants from the Department of Children and Family Services, specifically forming support and units around a family-based case management program, including respite support for the family, relative caregivers, and also embedded support groups. So if you can imagine, prior to the development of a kinship network, if you were a grandparent in their mid-50s and had 4 children under your care, those 4 children prior to the development of a kinship model of care could have 4 different social workers and 4 different financial eligibility workers, each working with your family. So 8 people working with your family around these 4 children, rather than thinking about the family as a unit. And so again, this is taking, I think, an individual issue and then thinking about it, about the layers of the onion behind it, and how both research as well as engagement with policy could help to promote the health and well-being of people who were in fairly stressful situations during that critical time. I'm going to go to the next example now and to tell you a little bit about some of the work that I've been doing since 2009 in the city of Chicago at the University of Chicago. The photo that you see here is drone footage of the main campus of the University of Chicago in the lower part of your screen, reflecting upon the south side of onto the north side of Chicago and into the downtown area. Lake Michigan is up in your upper right-hand corner there. Sometimes we like to refer to ourselves as the third coast here in Chicago. But oftentimes people who think about the University of Chicago have this particular image in mind, or they have this image in mind. And they think about the south side of Chicago, that area that's just to the south of the university campus, as being one that is quite violent, where there are no options for healthy food, where there are people who are being killed in the streets every single day, or a place where there's a lot of gang activity. However, the people who live on the south side of Chicago have a very different image of where they live. They have an image of the incredible history on the south side of Chicago. Upper left-hand side of your screen, just below where it says Little Black Pearl, is a picture of Dr. Daniel Hale Williams, African-American surgeon who performed the first successful open heart surgery in the city of Chicago at a Black-owned and operated hospital on the south side of Chicago, Provident Hospital. They think about the history of the blues and performance in the city of Chicago. They think about the arts in Chicago, and also some of the political involvement in the city of Chicago, including this picture here in the center of your screen of former First Lady, Mrs. Michelle Obama, when she was an employee at the University of Chicago and the head of our civic engagement and community affairs at the medical center. Again, different perspectives on how people view the South Side internally versus the people who live there. Origins of the University of Chicago, actually, it was founded as a community engaged campus with one of its initial divisions of extension. And you can see here a quote from the university's first president, William Rainey Harper, and thought that there were opportunities for partnership with the community through the methods of the university could be brought to the larger community. For those of you who have social work backgrounds, you may be familiar with Jane Addams and Hull House and really the origins of social work in the modern age. President Harper actually taught courses as a member of that division of extension to new immigrants who came through Hull House as new immigrants back in the late 1890s and early 1900s. Community engaged campus. This is Dean Sophonisba Breckenridge, who was not only our first dean of our School of Social Work at the University of Chicago, but also a graduate of our law school, who felt that we really should incorporate a philosophy that links accurate measurement of social conditions with solutions to social problems. I think this particular perspective is especially important as we think about some of the common measures that we are being asked to incorporate into our work through our P50 grants at our respective institutions. However, the question of community engagement over time has had a very long and winding road with community and the University of Chicago, with some of the issues that you can see detailed there, including historic mistrust of the university based sometimes in perception and sometimes reality in terms of thinking that the university is after land grabs, that they're not good neighbors, et cetera. And then also some of the racial and ethnic discordance of the university versus the surrounding community, which is primarily African American. Quite a bit of urban upheaval in the 60s and 70s and the university's role in it. And then also because within the primary service area for University of Chicago Medicine, we have 6 of the 8 poorest communities within the city of Chicago. We are a private institution, but our community partners say we should be able to do a better job of caring for the poor and satisfying community benefit. And so again, lots of tension in terms of these particular relationships. But we wanted to look at ways in which we could at least try to address some of these things through scholarship and science. By doing so, I had the opportunity to work on a program with Dr. Stacy Lindau as the principal investigator, which started out in 2009 as the Southside Health and Vitality Studies, later evolved into a program called MAPSCORE, meaning meaningful and productive science and service to the community, and asking these questions. What resources exist in the built environment that can influence health? And are the existing secondary data sources in the built environment, such as Dun & Bradstreet information, Yelp information, are they accurate? And then how can we take the data in the built environment and leverage it in order to improve health? The community also had a series of questions. What are the resources in my community? And so again, some matching in terms of the interest of the university versus the community. How do these resources reflect on the vitality of my community in the broadest sense? And so not just thinking about health disparities and health outcomes, but what about economics? What about employment? What about education? And then something that was very targeted for the health and well-being of the community residents. They were very interested in figuring out ways in which, how can you provide opportunities for our young people in our communities? And so for that, Southside Health and Vitality Studies and MAPSCORE were born. In terms of what's in it for the university, I talked about that in general terms early on, but some of the things that we focused on, we really wanted to improve our reputation and trust with our neighbors. And a healthy and vital community is good for not only the university reputation and spirit and brand, and then the issue of having energy amongst our investigators in order to help to promote social justice for our communities. Sustainability and complementarity of university community investments and programs was also something else that we wanted to focus on. Our community members wanted to have a seat at the table in the planning, implementation, and dissemination of the results of the studies, as well as transparency in terms of how we work together, and the creation of job and educational opportunities for young people who worked in the community. So this is our community engagement process. We worked closely with our local initiative support Corporation of Chicago New Communities programs, which were community-based organizations responsible for holistic approaches to community redevelopment. We also partnered with direct service providers, We connected with aldermanic leaders as well as faith leaders on the south side of Chicago. And although this work was facilitated by our Office of Community Affairs, they were junior partners in doing so because we wanted to make sure that the study investigators were fully invested in this. And so they did not serve as a go-between the community and the academic investigators, but they helped to make the introductions in terms of our work with these various organizations. We developed a community advisory council that met 9 to 10 times a year, in which investigators, study staff, and key community informants were invited to come to the table together in order to work on the planning and implementation of the studies. These meetings were completely open to the public, and so not only did we have community members and investigators and study staff, but we sometimes had members of the press to attend these meetings in order to observe the work that we were doing. In addition, as the work developed, we also would have not only community forums around the planning and implementation, but also for results dissemination through large community town halls. The photo that you see here was actually in December of 2008. I was in attendance, and it was about a month before I actually came on board, in which this meeting of investigators and community members took place in a community setting. It's an arts organization that also has an alternative school called the Little Black Pearl Workshop. And so we gathered people around the table in order to not only present some of the data around health disparities, but also to task people from their perspectives what information would be needed in order to help them to make decisions about how to make investments in their communities and how could they help us. And so we as university members went to the community. The person in the photo here was our former executive vice president at the University of Chicago Medicine in the area of community engagement. And he had a special relationship with community here and also understood these issues in that he'd been a community engaged researcher in the area of men's health during a Robert Wood Johnson Clinical Scholars Program, and then later on became the state health department director. So again, various perspectives in community, as well as having done work in community. We didn't only go out to community, but we also brought the community into the university in that we would have meetings in our boardroom at the University of Chicago and involve community members around the table along with our investigators in order to have these periodic planning meetings and implementation meetings for the project. Listing here of our Chicago partners from the community, including our survey lab associated with NORC, the Office of Civic Engagement, the Office of Community Affairs. We hired college students to work with young people in the program through the Metcalf internship program. Number of community partners as well. And in particular for this project, our community partners, I think, brought a very important perspective to this. And I'll drill down on that in a little bit, but a listing of the community-based organizations that we partnered with. In particular, excuse me, the Greater Auburn Gresham Development Corporation said, we want you to hire our youth to go out to map the assets that exist within our communities and to have mentorship from your University of Chicago college students in doing this work. We can provide some funding for the high school students that are doing the mapping through a city program called After School Matters. The only thing you need to do is to set up both the mentorship through the college students, as well as once a week, a special session where the college students and the high school students come together for educational programming to learn a little bit more about Chicago communities, about epidemiology, about health disparities, et cetera, so that we can bring these two groups together. Again, I mentioned After School Matters through this particular funding and the various organizations throughout the city that were able to partner with us on the mapping. Another map here, 2009, we mapped the communities that you see here in pink. Area 41 is where the University of Chicago is located in Hyde Park. And so we mapped not only Hyde Park, but the communities that surrounded it. And then another community somewhat distant to it in the East Side community, South Chicago community as well. However, we were able to spread this mapping program to over 50 communities within the city of Chicago, providing over 500 meaningful and productive work experiences for high school youth and then their college-age mentors as a result of that work up to 2016. The 50 Chicago community expansion from those 7 communities that I showed you on the map. And in addition, we were able to generate interest in other communities, including one area in New York City, Niagara Falls, New York, as well as Nash and Edgecombe counties in North Carolina. We also had some international interest in this work in Dublin, Ireland, in terms of mapping communities there and working with young people, specifically between the ages of 13 and 18, to actually go out and to do the work. We took the information from this work from the beginning to look at ways in which we could build community engaged health research and science and service to the community by looking at the roles of what the roles that community members could and should play in assets and mapping these assets in communities. And you can, the reason why I'm sharing this particular publication with you from Preventive Medicine is that of the people who were involved in this project, there are 4 that are community members themselves. And so we were able to have community members to not only share their expertise in a consultative fashion, but also to have an article published under their names in the peer-reviewed literature. We also expanded this work into a study that was done called Community RX, in which we took the information that was gathered from communities and included that into the electronic health record to create a prescription for services for people who were being seen in our federally qualified health centers and our adult and pediatric emergency department, which led to a publication in Health Affairs here, linking clinics to community services as well. And so not only were we able to provide a service to the community, but also to provide active scholarship for those of us who were involved. A little bit of a quote here from the former president of the W.K. Kellogg Foundation in terms of our charge. Universities can and must play a role in combating the problems that plague our communities, from poverty to crime to racism and more. And the ability to do so should be done in partnership with community-based organizations. I have another quote for you that I think is quite relevant to our work. If any of you are familiar with any of the work that the lawyer Brian Stevenson has done through his Equal Justice Initiative in Montgomery, Alabama, he's also the author of the book Just Mercy. I think that it's very applicable to some of the motivating factors behind my work in the area of community engagement and community engaged research and the process involved. And that is, oftentimes you've got to get close to the problem. By being able to ask my patient questions of why are you here? Why have you missed so many appointments? Why are you here with your granddaughter? What is that relationship? And what else is going on within the community? Absolutely critical in being able to take the spotlight from one and then expanding the aperture of that spotlight to think about things from a population basis. Being able to change the narrative. And that goes to thinking about the assets that exist within the communities, including both the physical, structural assets, as well as the assets of the people, and thinking about ways in which one can work together in partnership. Making sure that you remain hopeful. Oftentimes when people think about coming to the South Side of Chicago, and I've even encountered this when I've traveled internationally, and they'll say, hey, where are you from? Chicago. And they'll go, oh, Chicago, bang, bang, because they think about Chicago as being a very violent place. That's not the attitude of the people who live on the South Side of Chicago. They actually are very proud and hopeful around their particular circumstances. And they're not only hopeful in a Pollyannish sense, but they're actually working and doing things in order to help to change the narrative in their communities. And then the other thing is that sometimes it means being a little bit uncomfortable and getting close to the issues. If any of you have read Brian Stevenson's book or heard him speak or even saw the movie Just Mercy that was made about his work, he didn't always have successes in his work. Some of the defendants that he had that were on death row, unfortunately, were executed by the state. And sometimes we will have situations in which we have some challenges and sometimes are not as successful as we would be or would like to be. I certainly experienced that in my work in co-founding Grandparents Who Care in terms of some of the family relationships. But I think overall, in terms of the work that I've done over the years, that it's been incredibly fruitful and rewarding. And it's the reason why over the course of a 30+ year career at this point, I've remained committed and engaged in doing work in this space to promote social justice and health equity. I will stop there and sharing my slides. Thank you so much for your time. And I think that we've got about 10 minutes or so for questions.
Wonderful. Thank you, Dr. Miller, for that outstanding presentation. It was wonderful. Thank you. I don't see any particular questions in chat, but perhaps individuals would like to raise their hands and ask questions directly. If not, Dr. Miller, go ahead, Dr. Charlebois. You're on mute.
How unusual for me. So, Dorian, thank you so much. Can you talk to us about your successes with kind of closing the loop and getting the research results and things, back into the community, and what's really worked and been great for dissemination?
I'll give you an example of a tailored dissemination of sharing results, and we'll go back to the MAPS Core and Southside Health and Vitality studies as an example. And I think that this is really critical in terms of thinking about not only the how, but the when in terms of sharing results. When we finished our mapping for the Auburn Gresham community and shared results with the leadership of their community redevelopment agency, they were very interested in finding out about the number of churches that existed in the community, because they were interested in economic development, and the churches in the community, which they knew that there were quite a few, obviously are not-for-profit organizations and that are not contributing to the tax base for the community. But they were also interested in crime statistics. And so when we shared information both about crime statistics as well as the number of churches, they were very concerned that if there was more widespread knowledge around crime statistics, that would actually inhibit their ability to attract new businesses to the community. And so we had to be they said, thank you for the information. We want to make sure that we're framing the right story about our community in order to help to enhance economic development within the community. It was actually through some of the data that we were able to share with them that led to the community being able to get a new super Walmart built in the community, because they were identified as being a food desert. And so again, knowing about where there were places to shop for grocery stores, something that didn't exist before, they had data from the University of Chicago and from this project to say, look, Walmart, this is what we need in this community. And they ended up building a Walmart there that's been in existence now for about, I believe it's been almost 10 years at this point. And they were able to do so through this data. So again, being able to not only share the data in smaller groups, but also larger groups as well, and then looking at the impact of that data, I think is very, very important.
Thank you. That's terrific. Last week I was talking with the CDC Health Equity Scholars, and we were discussing the idea of, from the academic standpoint, from us, in making it standard in journal articles, to include a community author, but as part of our discussion sections, always having a community written paragraph about what the impact or interpretation of what's being presented is for the community. And the example you just gave about where, hey, this data could be, could actually be misconstrued and actually harm the community goals and environment without the proper context, is a situation like that's just so illustrative of the need of doing that sort of thing, and pushing the community involvement, in our academic process all the way through to that dissemination end. So thank you.
Yeah, I'll also mention another publication for those of you that are early stage investigators that's really important if you're interested in having not only articles published in the peer-reviewed literature, but also having community partner perspectives. And that's the principles of community health partnerships. Publication comes out of the Johns Hopkins Press. Very open to not only articles that are co-authored by academics and community partners, but also areas in which the community partners can do their own publications and original investigation, essays, et cetera, as a potential resource.
Thank you. Dr. Miller, you alluded to the importance of establishing trust within the community, and also sometimes potentially in the approach that we have in resulting in that mistrust. And I'm wondering what your approach is in expanding or assessing the knowledge of the community to ensure that there is a mutual understanding that this is done with respect, and also in preparing potentially community-ready information.
The listening sessions are absolutely critical, and listening a lot to community needs. In another program that I run at the University of Chicago called Community Grand Rounds, I actually conducted a 6-month period of listening sessions, both group listening sessions with community-based organizations as well as individual meetings, in order to learn about what were the needs in terms of community education, and then invited our community members to the table in order to co-plan the Community Grand Rounds series that we operate. So it's a series of bi-directional educational seminars that are focused on community, in which we have not only university investigators at the table, but people in the community that are doing work in the same space to present on topics to the community in very friendly, community-friendly formats. And so we go to faith organizations and schools and senior citizens buildings to have these particular seminars. They take place over a 2 to 3 hour period, either on the evening or a weekend. We include a meal along with it. And we've also been very creative in the way that we've presented information based on the recommendations of our community partners. And so we consider ourselves to be the junior partners, but we've included artistic events, movies, cooking demonstrations, plays, I mentioned movies a minute ago, concerts, those types of things as a part of the education for community, along with panel discussions. And so it's much more of a event rather than having a lot of academic, and this is a quote from the community, not from me. We don't want to have a bunch of academic talking heads pointing fingers at us, telling us what to do. We want to make sure that the academics know what we're doing in the community and vice versa. And so that program is actually shared between our Urban Health Initiative through UChicago Medicine and our Clinical and Translational Sciences Institute. So again, the sharing of those two pieces there, I think helps, because if you think about T4 translational research, for those of you who are either have or affiliated with a Clinical and Translational Sciences Institute, being able to not only share with community, but also hearing back from community about their needs, but also their preferences and their values around that, incredibly important in terms of the development of trust and engagement with the university community.
Wonderful. Thank you for that information. We have a comment about the grandparents program being, it was very informative and wonderful to hear about it. We have a question. I'm sorry, Dr. Defeccio I'm so sorry if I'm mispronouncing your name. I apologize. Go ahead.
No, it was fantastic. I just so enjoyed this presentation, and I have like a question / comment. Dr. Dugan, I part of community engagement, community-centered activities for a collaboratory for cure for HIV. And one of the things I hear again and again from my community members is how important financial mobility is for folks, and people are asked to be on the cabs. Yet the NIH has a conflict of interest, so people cannot be paid to be on the cabs. But people are asked to spend a lot of time attending the calls or providing input or going and educating. And what would be your suggestion for me as a researcher to advocate for changing some of these rules, which are community members are asked to do often a bunch of activities, but they're not getting paid for it. And when I bring that up, people tell me I'm naive. So
we pay members of our Community Stakeholder Advisory Council, Community Advisory Review Council for our Institute for Translational Medicine, and we provide them with an honorarium for their participation. And so there may be some specific issues around specific projects that for whatever reason may not allow it. So I think investigating that a bit more, but there are also other things that could be done potentially, whether I hate gift cards because they're, difficult to track and other things come up around it, but also provision of if there is reimbursement if people are driving or for transportation. If there are childcare issues involved for the people who are engaged in that way, being able to provide some support in that way. For us, we also, the cachet of being called a community consultant for my Community Grand Rounds program was very important because people put that on their resumes to say, I'm a community member and I may only have a high school diploma, but I'm a consultant to the University of Chicago. A lot of leverage there in terms of being able to think about perhaps non-monetary benefits to this work.
Yeah, I love that idea of the consultancy and being people in councils and being able to give them some money that way. Yeah, really appreciate it. Thanks for your talk.
Thank you.
Wonderful. Dr. Hong, you have your hand up.
Thank you. Dorian, that was an amazing talk. And it's funny is that you're just across the hallway from me. But I wanted to ask something about kind of engagement with the community about, do you feel like we are sometimes reinventing things or redoing things? Because people move on, people, the people we interact with may not be there the next time we have a community engagement program. What is your advice about, I just have, are we making progress, or what do we have to kind of repeatedly do and expand? And how do we get a sense that we're actually making progress with community engagement?
I think that one of the points around, even though the project may be over, but the work is not, and one of my earlier slides is incredibly important, and that is to keeping a warm pipeline with the community organizations that you've been working with. And it's something that I think that as work is developed over time, that is one of the ways in which that takes place. Our partners at Rush, and particularly Dr. Beth Lynch and her work with the Alive Faith Network, has made it possible for us to be able to work with that particular program on the project that you and I serve on currently. We had a community town hall for our P50, the Chicago Chronic Conditions Equity Network, last week with the Greater Auburn Gresham Development Corporation, but my relationship with them goes all the way back to 2008 in terms of the work with the Southside Health and Vitality Studies. And so it's been over time, hi, how are you, what's going on? And not just around a project, but if there's a fundraiser going on, or if they say we need to have a speaker around X or Y, would you come and talk to us about the history of the South Side of Chicago or other things? Again, it shows that you have an investment in the organization and helps to keep that a warm connection between you and the organization, so that if opportunities come up for projects at a later time, they'll go, oh yeah, sure, we're willing to work on that. Or yes, I have somebody that's working with you on Community Grand Rounds, and you've got another project that you'd like for us to work on. Of course, we can do that. So again, it's about the maintenance of the relationships over time.
Fantastic. We are now at the top of the hour. Once again, Dr. Miller, thank you so much for that outstanding presentation. We learned quite a bit, and I wish everyone a wonderful rest of the afternoon. Thank you.
Thank you.